Hello everyone, and welcome back. Today we're presenting a rare but critical case of left ventricular papillary muscle rupture due to acute myocardial infarction following transcatheter aortic valve replacement, or TAVR. This case emphasizes the importance of post-operative monitoring in high-risk patients. Our patient is an 82-year-old woman diagnosed with severe aortic stenosis. She was referred to our hospital with shortness of breath and a characteristic ejection systolic murmur. Preoperative echocardiography revealed a valve area of 0.85 centimeters, a peak velocity of 4.3 meters per second, and a mean pressure gradient of 41.6 millimeter-Hg, with a preserved left ventricular ejection fraction of 60.4%. The patient's mitral regurgitation was mild, and coronary angiography revealed no significant stenosis. A transfemoral transcatheter aortic valve replacement was scheduled for this patient. Preoperative computed tomography revealed that the heights of the ostia of the right and left coronary arteries were 12.1 millimeters and 8.7 millimeters, respectively, indicating a potential risk for coronary artery occlusion. Additionally, the size of the sinus of Valsalva was measured at 29.4, 29.0, 28.8 millimeters. The patient's preoperative CT also showed an aortic valve calcification score of 3,988 AU, indicating a highly calcified valve. A self-expandable valve was chosen to reduce the risk of aortic dissection. The TAVR procedure was successfully completed without coronary obstruction, and the patient showed stable hemodynamics initially. Post-surgery, the patient developed complete atrioventricular block, and a pacemaker was implanted. However, on postoperative day 13, she suddenly developed dyspnea. Coronary angiography showed stenosis of the left main coronary artery, and percutaneous coronary intervention was successfully performed. Despite this, on postoperative day 16, she developed sudden dyspnea again, leading to emergency transoesophageal echocardiography. The echocardiogram revealed severe mitral regurgitation caused by rupture of the anterior papillary muscle of the left ventricle. This rupture led to significant mitral regurgitation and was confirmed to be the cause of her sudden symptoms. In the early stages after surgery, echocardiography showed an ejection fraction EF of 65.3%, with no wall motion depression and trivial findings of mitral regurgitation. However, later, echocardiography on postoperative day 12 showed an EF of 38.8%, decreased wall motion from the anterior septum to the apex, and the MR showed trivial findings. During the surgery, a median sternotomy was performed. Cardiopulmonary bypass was established, and the left atrium was opened using a transeptal approach. The anterior mitral leaflet and ruptured anterior papillary muscle were resected. A tissue valve was implanted in the mitral position without any complications affecting the TAVR valve. The patient's postoperative course was uneventful, and she was transferred to the ward after 7 days. After surgery, the patient showed significant recovery. Pathological examination of the papillary muscles suggested early infarction occurring 1 to 3 days after onset. This confirmed that the rupture of the papillary muscle was caused by myocardial infarction following the TAVR procedure. The patient's postoperative course was smooth, and she made a full recovery without further complications. This case highlights the risks associated with transcatheter aortic valve replacement, including severe mitral regurgitation caused by papillary muscle rupture. In such cases, emergency mitral valve replacement is critical for patient survival. This patient's condition was carefully managed, and she made a full recovery. Thank you for watching. Don't forget to like, share, and subscribe for more medical case presentations. See you in the next video.